Thank you so much. Well, hello everybody, and thank you for joining us today for this important webinar on providing an excellent patient experience. I'm Kate Stenyam, and I'm a program manager with the Delta program at the National Rural Health Resource Center. The Delta Region Community Health Systems Development Program is providing this webinar today, and it is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. This is the first webinar in a three-part series, and the webinar today, like I noted before, is being recorded, and it will be posted to our website. The recording will also be sent out to all the participants with the slides as well. Before we get started on today's webinar, I wanted to note the dates for the next two sessions. So session number 2 will be April 15th, that's part 2, and April 22nd will be part 3. So as we move along today during the presentation, we really encourage questions and discussion. So you can either unmute your line and ask a question that way or put in a comment that way, or you can utilize the chat box. We do ask that if you're not speaking, please keep yourself on mute to cut down on any feedback. Before we go ahead and get started as well, please take just a quick minute to find that chat box and type in your name, your title, and your organization. This really helps not only our staff, but particularly our presenter get a good feel of the audience that is all on the webinar today. So next slide, Patricia. We have 2 quick pre-polling questions that we would like you to answer before we get started. So Patricia, please pull up the first polling question. Thank you. If you could everybody take just a couple seconds to fill this out. So it is, I am blank in my understanding of how HCAHPS survey tool evaluates the patient experience. Are you confident? It's anywhere from confident down to unconfident. Patricia will give you about 10 more seconds to put your answer in there. Okay, thank you, Patricia. There are the results. Thank you. So we have 14% of you said you're confident, 50% said somewhat confident. We've got 17% at neutral, 11% somewhat unconfident, and then 8% are unconfident. So pretty big range right there. Thank you so much. Patricia, could you pull up the second polling question? Not seeing that polling question yet. And we'll just move on and let's see. Oh, there we go. I am blank in my understanding of how my role impacts the patient experience. Same thing. Are you confident down to unconfident? Are you understanding how your role, your particular role, impacts the patient experience? We'll give just a few more seconds for you guys to put your thoughts in there. Great, thank you so much. So we had 56% confident, 36% somewhat confident, 7% neutral, and then just 2% as unconfident. Thank you so much, Patricia. Okay, next slide. So in the session today, participants are you're here to develop an understanding of HCAHPS and other patient experience surveys, and also to learn how to establish those high standards of service excellence and the role that empathy plays in providing an excellent patient experience. So now I'm going to take a minute to introduce our presenter for today. Our presenter is Carla Wilbur, and many of you on the line today have already met Carla, but I would still like to do a little introduction for those of you who have not had the pleasure to meet Carla yet. So Carla is a senior consultant with Stroudwater Associates She's a nurse administrator with a background in critical care, education, and emergency services. She was previously the Director of Enterprise Excellence at Wake Forest Baptist Health at Lexington Medical Center. And there she facilitated lean transformation and was responsible for the development, implementation, and ongoing assessment of comprehensive performance improvement and lean redesign activities within the healthcare facility. So with that, I'm going to be quiet now, and I'm going to turn things over to Carla to get us started.
Thank you, Kate. Next slide. I'm happy to be here with you guys today. And again, just reiterating what Kate had said, we're going to go over CAPS, HCAPS best practice actions, establishing high standards of service excellence, and the role of empathy. Next slide. So CAPS is the Consumer Assessment of Healthcare Providers and Systems surveys. Those reside in CMS, and there are a whole host of patient experience surveys. All of the surveys designated as CAPS have been approved by the CAPS Consortium, and that's overseen by AHRQ, the Agency of Healthcare Research and Quality. CAPS surveys are important because CMS wants to improve, of course, always trying to improve the healthcare in the United States. Next slide. So this is just a list, and I won't go through all of these, of the CAPS surveys. The one that we're going to really be focused on more today is the hospital CAPS, so it's known as HCAPS. Next slide. So HCAPS, again, Hospital Consumer Assessment of Healthcare Providers and Systems. So it's specific to our hospital. And it's designed to pull data about our patients' perspectives of care for us to then hopefully use the information to drive improvement within our own organization due to the fact that these are publicly reported. Prior to HCAPS, there were no real publicly reported and standardized surveys. So you would never know how you were doing as far as patient satisfaction and the patient experience against another organization. So the publicly reporting of the data that is retrieved from these surveys helps to drive that accountability and hopefully, impart a little bit more transparency in the data and make it something that you use to drive your own improvement in your organization. Next slide. So it is a standardized survey instrument, 29 items. It's a data collection methodology. As I mentioned, we can compare ourselves to others. The basic survey is apples to apples. So the same questions are asked of all hospitals in the basic survey. Now, hospitals do have the opportunity, if they so choose, to add customized questions to their surveys through their survey vendor, but the basic survey questions are standardized throughout. Typically, the survey is administered anywhere from 2 to 42 days after discharge. We recommend that if you can have your survey vendor send the survey as early as possible. Patients and family members seem to have a better return rate when these things are fresh in their mind. The survey does come in multiple languages. It was nationally implemented in 2006, gave the hospitals a little bit of time to kind of craft their own processes, and then the scores began to be publicly reported in 2008. There are over 4,000 hospitals that participate in HCAPS. These are administered by mail, telephone, mixed, which is mail and telephone, and then active interactive voice response. And as you can see, the mailed surveys are the most popular, and that's the latest data of 2019. Next slide. So this is just to show you the first page of the HCAP survey. Every so often they'll go in and update a few questions, but since the pain management questions have been removed. They haven't done anything more with the questions since then. Next slide. So the first composite measure is the care from your nurses. So there are 3 questions, all focused on courtesy and respect, listening, and how often did a nurse explain things in a way you could understand. Next slide. So this composite measure is communication with nurses. And some of the best practices are to make sure that you provide training to your staff related to empathy and effective communication, using Teach Back, which is a methodology to ensure that we have communicated well with our patients and that they understand what we were teaching them. Using health literacy principles, and there will be a little bit more on that later. And then Ask Me 3, which is a free methodology that you can use and download posters and brochures for your patients and for the hospital and clinics as well. Using whiteboards is a great thing to do to communicate all of your daily goals. And then Aid It. Many of you guys that I have worked with before use Aid It to just kind of, it's a methodology to help you stay on track, acknowledging, introducing, duration, explanation, and thanking. It's a Studer principle, and it's a very good communication framework. And then anytime that you can possibly sit at the bedside with your patients, do that. It always tends to make the communication a great deal better. Having some memorable conversations with your patients, starting off about something that's maybe personal in their life, like what do they like to do? What are their hobbies? To drive that communication and trust as well. Next slide. The next composite is identical to the nursing composite, but it's the care from doctors. Again, courtesy and respect, listening carefully to you, and explaining things in a way you could understand. Next slide. Again, it's important for providers to have training around empathy and effective communication. Providers should also use Teach Back and engage your patients and family members in your care conferences. If you guys do the interdisciplinary rounding, make sure that patients and family members are part of that care planning and care conference. Ensuring that all the patient feedback that you find from your HCAHPS results are shared with your providers. If providers don't know what's being said about them, then they don't know where maybe they need to drive some improvement. One thing that we have found that works really well to help communication with the providers is having pads and pens or pencils at the bedside so family members can jot down some notes. Not always are they there or think of what they wanted to ask the provider if they are there when the provider rounds, but this just helps them kind of gather their questions. And you can also use your whiteboard for that. I was with a family member in the hospital one time, and they had a section on the whiteboard for questions because we weren't always there when they rounded. So we would write questions on the whiteboard. That helps also to improve communication. And again, if the providers can take the time just to sit and listen, it doesn't take any more time to sit than it does to stand at the bedside when they're rounding. Next slide. The next composite is your experience in the hospital. This one has a screening question. So if the patient did not need help from nurses or other staff in getting to the bathroom or the bedpan, then they don't answer the other 2 questions. But if they did, then they're asking, how often did you get the help that you needed as soon as you wanted? And then after you press the call button, how often did you get the help as soon as you wanted? Next slide. This is all about responsiveness of staff. And the most important thing I think with responsiveness of staff is putting into place within your organization the no pass zone. No pass means that anyone in the organization, when they see a call bell, that they can stop at that room, knock on the door, introduce yourself, and ask, what can we do to help you? No one is going to ask a non-clinical person to do something clinical. So if the patient needs something clinical, then you go get the nurse. But if you happen to be dietary and you walk by a room and you see the light on, just stop and ask what they need. That is immediate responsiveness of staff and will definitely help improve that score. Next slide, please. Your experiences in the hospital. So again, this composite does have a screening question too. They just wants to see if, they were given any medicine they had not taken before. So if they did have some new medicine, they want to know before giving you the new medicine, how often did the staff tell you what the medicine was for? And how often did the hospital staff describe the side effects in a way you could understand? Next slide. The important thing there is to make sure that we teach about the medicines. One of my greatest recommendations is the M on the board. So if you have your lovely whiteboard and this patient is going to have a new medication, put an M on the board, and that reminds everyone when they're passing meds that this patient has a new medication, and that they'll do a lot of extra teaching around that particular medication. And make sure that if you can at all possibly provide a pharmacist to visit patients at the bedside around their new medications. That helps as well. And then again, using that teach back to assess the patient's understanding of the medication, what it's for, and what the possible side effects are, can really drive home that education with communication about medications. Next slide. And when you left the hospital, it also has a screening question. So if someone goes to another health facility, then they would not answer this question. But if they went home or to someone else's home, they'll be asked, did the doctors, nurses, or other staff talk to you whether you would have the help you needed when you left the hospital? And did you get information in writing about what the symptoms or health problems to look out for after you left the hospital? Next slide, please. It's really, really important that we do a great readmission risk assessment, that we know whether that patient is high risk for readmission, so that we can address some of the issues that may cause them to be readmitted. We need that comprehensive shared care plan using the patient and family members' input in their care plan. We need to know who's going to be there to help take care of them when they get home, who may be able to do their grocery shopping or cook for them. If we miss that type of information and we don't create a really good discharge plan, then we're not setting our patient up for a good outcome. And of course, post-discharge follow-up calls are really, really important as well to ensure that they understood the discharge instructions. When people are ready to leave the hospital, sometimes they don't. They're excited to be able to go home, so they're not really listening to us. So the post-discharge follow-up calls are very important. And those admission discharge folders, always keeping the admission discharge folder at the side of the bed so that we can add information in it for the discharge. Next slide, please. So I mentioned health literacy a little while back. Health literacy is very, very important to focus on. This was a vignette that came from Joint Commission a few years back about a 68-year-old man, and he was readmitted after heart failure. He had been discharged and he was readmitted, and he came back with his full bag of medicines, which we do like to see them bring their medicines back when they come. The problem here was that the medicines had not been taken. And then he was asked why they weren't taken, and he began to cry because he had never learned how to read. That should not have been missed. If we do a good assessment and we do a very, very good risk assessment, we would know whether that patient could read or not, and then could make adjustments to their medication information so that they could take them appropriately. Also, as noted there, it was stated that 40 to 80% of information provided by healthcare practitioners was forgotten immediately. So it's really important that we do a really good job of explaining all of the discharge instructions and the expectations for their discharge and their time at home. Next slide, please. The next composite is understanding your care. So much like discharge, this is transitioning of care. So I had a good understanding of the things I was responsible for in managing my health. I understood the purpose for taking each and every one of my medications. Next slide. Care transitions is the nationally lowest score in HCAHPS. Typically, it is around 52 to 53%. As long as care transitions has been around, we still haven't made very much progress with it. So in addition to discharge planning, if at all possible, make sure we make follow-up appointments for our patients before they discharge, and make sure that we know that they have transportation to get there. How about developing a community care transition team? One of the hospitals that I worked with in Alabama developed what they called their joint health partners. So they have a community team that all works for the good of transitioning care for our patients. Evaluate all of your readmissions. Make sure that you track and trend them. There may be something that we're missing within our readmissions. And everyone at this point should be screening for social determinants of health. Social determinants of health account for up to 80% of health in our patients. And if people have food insecurities, housing insecurities, or other insecurities, other social determinants, they will not have a good transition back to home. Next slide, please. And again, make sure we're making those meaningful follow-up calls, and start early in their time with you. We have always heard that discharge should start in the beginning at the admission, and that's true. If they have complicated situations at home or complicated medications, we need time to figure all of that out and hopefully send them home with a good, successful plan. Next slide. The hospital environment is about how you keep the room and bathroom clean, and if everything is quiet at night around your room. Next slide. So make sure that we are doing some spot checks on our rooms. You know, cleaning of rooms is not just housekeeping's responsibility. It's every one of us. If we're in a patient room and we see something that needs to be cleaned, either we can clean it or get the person that's responsible for doing that particular task. It's important that we keep the rooms tidy. Another thing that, you know, I have seen that works really well in hospitals is the little tent cards, so that you have the housekeeper's name, the phone number to call if you have a problem, so that they know who to contact, and make sure that everyone knows, you know, who is responsible for doing the spot cleaning. Do we have a schedule of spot cleaning or spot checking of rooms to keep up with them to make sure everything's done on time for our patients? Next slide. Again, I had mentioned the tent cards. Our hourly rounding, implementing intentional hourly rounding can help with the cleanliness of the environment too, because it gives us a chance to see what's going on in the room and if we needed to straighten up or, you know, empty the trash or whatever may be the need. Next slide, please. Quietness at night is really difficult for a lot of our hospitals because of the way that the nurses' stations are designed. Maybe the rooms are very close to the nurses' station. And sometimes with little pods of rooms, the noise just kind of travels down the hall. So if possible, you know, use a quiet zone sign to keep, you know, other patients and family members reminded, and our staff that this is a quiet zone, eliminating the overhead paging at night. And most importantly, I know from working in the hospital for so many years, our floor, our environmental services always wanted to clean our floors at night, which we understand and appreciated. But the floors near the patient rooms, it's best to do those when it's not time for the patients to be sleeping. Next slide. Another thing that I've seen, and I know that many of you use Medline products, Medline and probably some of the others have these packs. They're called quiet packs, and they have earplugs and eye masks in them. Those are a nice thing to have for our patients for sleeping. Next slide. And then the overall rating of the hospital. So the last two questions are from 0 to 10, how you would rate the hospital, and then would you recommend this hospital to your friends and family? Next slide. I've kind of had a problem with the willingness to recommend the hospital to your friends and family question, because it really should be worded more as, would you recommend the hospital to your friends and family for the services you received? But that's not the way it's worded. So we need to continuously speak positively about our organization, brag about our organization's strengths. I mean, sometimes our patients don't even know some of the services that are offered at our organization, and always thanking our patients for choosing our health system. Next slide. Now we're going to talk a bit about establishing high standards of service excellence. Next slide. It's all about building accountability, and that's related to the expectations, the service behaviors, job-specific service behaviors, service standards, and service targets. Next slide. So, what are the expectations? Well, we all have expectations when we possibly go to a restaurant or go into some other retail store. Service expectations have to do with what the customer or the consumer, which is our patient, wants from our service. So, those are our behaviors, respect and dignity. Processes, our billing and scheduling processes. Our environment, cleanliness, is it convenient? And can they navigate? Can they navigate through the halls of your organization? If you brought someone in to go to a certain place in the organization, how's the signage? Next slide. Service behaviors, those are things what the healthcare providers and staff do and say for our customers. I had mentioned AIDIT. That's a great methodology to use to remember the certain things that we should do during our communication. And there's many, many, many more. HEART is a communication technique from the Cleveland Clinic. Hear, empathize, apologize, respond, and thank. So those are specific service behaviors. Next slide. And then there are job specific service behaviors. And these are things that are a little bit more specific to your specific role. So that would be service protocols, scripts, detailed role and responsibility descriptions, much like your job description, and standard work. If there is something that is specific to this particular job, then it should have a standard work where everyone knows that specific service behavior for that specific job. Next slide. And then service standards. Those are promises that your service makes. So this is based on what you know your customers want most from you. And this is something that you should continue to revise, to measure, to make sure that we're always driving improvement efforts in our service standards. Next slide. And service targets. Again, the goals that we have established because we know that it's important to our customers who are our patients and our family members. We want to reach those goals and have a good impact on our customer service. So we have to continue to move the bar. As long as we're going in the right direction, that's great. I always tell people, don't let perfect get in the way of good. As long as we're moving in the right direction, then we're making improvement over time. Next slide. The role of empathy in healthcare.
Right, Carla, I'm going to jump in here quick just to check and see if anyone had questions. And we did have one question come through the chat box. So before we kind of move into this next section of the presentation.
Okay.
So we had a question from Grove Hill. Surprised that a higher percentage of hospitals do surveys by mail versus telephone calls. Is there any data of mail return rate success versus calls?
Not really. I have hospitals that I work with, and every hospital that I work with, I look at their return rates, and there's probably about, I would say probably about 75% of the, well, maybe 50-50, closer to 75% of the hospitals do mail. Some have done telephone in the past, but those that do telephone that are successful with it have a pretty good return rate. The problem with the telephone recently is that people have gotten used to the fact that they get so many spam calls, and if they don't know the number that's calling them, then they typically aren't going to answer it. The companies that do, the vendors that do the telephone usually have it on a 3 to 5 call cycle at different times of the day so that they could possibly catch the patient. But what we hear most is that they're just not going to pick up the phone. So the mail seems to be better in that population, but I think it's specific to your area. One thing that you can do to improve your return on a telephone survey is if you can get the vendor's phone number and have that as part of your discharge plan or your discharge information, and let them know that you may receive a call from this number, and we really want you to take the call and let us know how we did. We want to make improvements in our service, and so if you're able to provide that number for them, then they may be more apt to pick up the phone. Is there anything else?
Great, thanks, Carla, and thanks, Grove Hill, from the question. Just a reminder, if people, if you have questions, you can pop them into the chat box, or you can unmute yourself as well.
Thank you. Okay, the role of empathy. Next slide, please. So this is one of my favorite quotes. I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. That's Maya Angelou, and it's so very, very true. And I think about that in some of the unfortunate opportunities I've had to have to use healthcare services. It's always about how they make you feel. We have to remember that. Next slide. So there's a little bit of difference here between satisfaction and experience. Patient satisfaction is more about their perceptions of care, and the experience, which is an end-to-end journey through the entire continuum of care, is more about how we make them feel, not just the quality. Next slide. Empathy is defined as the ability to understand and share the feelings of another. Empathy has been known to be probably the most misunderstood term in the world of healthcare. There is a gentleman who wrote a healthcare book on empathy, and he was mentioning that it's more like I might be you or I am you. Empathy is not sympathy. Empathy is more of the definite the ability of understanding and sharing that person's feelings. Next slide. Known as the key ingredient to enhancing the patient experience, empathy is more than a diagnosis or a treatment. It's definitely thought to build trust and reduce anxiety and stress. It has known to improve the plan of care adherence. So keeping that patient, what we hear so often about compliance, empathy has been known to improve that compliance with the treatment plan. Demonstrates improved outcomes in their disease process, automatically improves communication. If someone is empathetic to your need, then the communication becomes more open since we've built a little bit more of that trust. It improves the perception of the care that's delivered, and it's just the right thing to do. Next slide, please. So there are three types of empathy. Cognitive empathy, when you can understand what that person is feeling. Emotional empathy, when you feel what your customer is feeling, and you make a connection at that emotional level. And then compassionate empathy, when you're moved to take an action or actions that reflect the needs and wants of each person. Next slide. The 4 habits model of effective and empathetic communication speaks to demonstrating empathy by being open to the patient's emotions, making an empathetic statement that you understand how they must feel, conveying empathy non-verbally, so that's in your body language, and then being aware of your own reactions. Some people do not react well to someone that's going through a very difficult emotional situation. And so we have to really be mindful of our own reactions to the patient so that they can see that we are very concerned and we are empathetic to their needs. Next slide. And demonstrate empathy verbally. Not that we need another acronym in healthcare, but there is a model that was designed by the Cleveland Clinic that says demonstrating empathy verbally with SAVE. So support, let's work together, acknowledge this has been hard on you, validating by saying most people would feel the way you do, and emotion naming, you seem sad. Next slide. So I like to always ask people if you can think of a place that provided great service for you. My favorite example is Chick-fil-A. Everywhere you go, all across the country, and I've been to so many Chick-fil-A's, I can't even mention how many, all across the country. Chick-fil-A is always consistent, pleasant, and they deliver great service. I've never been disappointed from the continuum of their care from the minute that you order and they thank you and I thank them and they say, it's been my pleasure. They always say the same thing. And then when you pick up your food at the end of the line, it's the same thing. It's been my pleasure. So that's a service that's just a small example of somewhere that always wows me. They can be consistent, they have good food, and they're very kind and pleasant. So think about a place where you've been where you've been impressed with the service and ask yourself why. And if Chick-fil-A can do that, we can do that in healthcare too. Next slide. Another favorite quote. It is a beautiful and mysterious power that one human being can have on another through the mere act of caring. A great truth, the act of caring is the first step in the power to heal. Next slide. Thank you. If there are any other questions, Kate?
I don't see any in the chat box yet, but please, if you have some questions or thinking, you can pop yourself off mute or put them in the chat box. While you're thinking of some questions, we have a couple post-polling questions for you to fill out. That'll just take a couple seconds. So Patricia, if you could pull up the first post-poll. Thank you so much. You can take a couple seconds to fill out that post-polling question. Patricia, I'll give you about 10 more seconds. Thank you so much, Patricia. So that time we're seeing 64% confident, 34% somewhat confident, and 2% neutral. And the second post poll. Thank you. Again, your understanding of how your specific role impacts the patient experience. You can take about 10 seconds to fill out that post-poll question. And then we just have one more for you after this. Thank you, Patricia. So at that time, we have 83% confident in understanding their role and how it impacts patient experience. We've got 15% somewhat confident and 2% neutral. And then just one more post-polling question, the third and final post-polling question. And it looks like as people are filling out that third and final poll as that gets pulled up, a question from Grove Hill, Carla. In the transitions of care questions, what in your opinion are the patients, in quotes, hearing when asked about their preferences post-discharge?
We have been trying to figure that out since the beginning of the care transitions question. But I think that what they're really hearing is that we want to know, we want them to be part of designing that plan of care. So in the discharge planning process, by involving them in the discharge planning, their preferences are taken in account. The problem that I've heard from several hospitals is that they feel that the patients don't accept, the patients don't want a certain thing. So they may not want to have this home health agency, or they may not want, a specific type of equipment. And that they feel as though, the hospitals feel as though that causes the patient not to answer that question in a positive way. But I think that the most important thing that we can do for that is to involve them in the detailed description of their discharge plan, that they're part of designing their own discharge plan, and use the word preference over and over and over anytime that you possibly can. I'm one of those people that I like scripting as long as scripting's not robotic. And if you can use preference in any time that you're caring for the patient, say for instance, the opening or closing of the door, what's your preference? Do you like the door open or closed? Do you prefer warm blankets? Or, anytime you can use preference, that continuously it gets in the mind of the patient as well. But involving them in that detailed discharge plan, I think, is key to improving the perception of preference, if you will.
Thank you so much, Carla. And we have another question that came on from Cindy Sadler, who is the CNO at Iron County Medical Center. Have you heard anything about when e-surveys will be accepted for HCAHPS? It's my understanding that vendors offer them, but CMS doesn't allow them, but instead only allow mail or phone surveys. I can only see this helping with response rates.
Right. The last time I checked, CMS was, they were evaluating the electronic surveys because they know that we're moving into an electronic world, basically, and even more so, I think, since COVID, where we've seen telehealth boom during COVID. So there has never been a date that I have seen anywhere, and if anybody else has seen it, please let me know. But I check the HCAHPS quality assurance information and site quite frequently, and I have yet to see anything about when that might be. But I do know that I get hospital and clinic information e-surveyed, but it's, it's never something that's accepted yet by CMS.
Great.
Thank you guys for the questions.
And then we have another, and Patricia, you can go to the next slide because we're on the Q&A now. And then another question from Franklin Hospital. Can patients in observation status receive a survey?
No, and that's the problem. So unfortunately, the way it's designed is that it have to be inpatient, one night stay, inpatient. Observation patients are not sent surveys. And for many of our hospitals, that's the problem with the return rate, is that we have such low volume in many of our hospitals of inpatient, acute inpatient status, that we don't have as many surveys sent. So therefore, we don't have as many surveys returned. Because a lot of our hospitals have, a huge population of observation patients. So no, they don't allow that. And I wish they did, because I think we still get the idea of the experience that we're providing, the care that we're providing with our observation patients that are treated no differently than our inpatient. And the only thing that's different is their level of care status. It's not that they're, being cared for, that they're in a different place. They're right there inside the hospital where we're delivering care. So, but that's not part of it right now.
Great questions. Any other questions? And remember, you can always take yourself off mute too if you'd like to ask a question. So we're waiting to see if more questions come in. Do you want to go to the next slide, Patricia? This is just a reminder for the next two sessions. So part 2 will be next week, April 15th, and then part 3 will be April 22nd. Part 2, the session is really going to focus on developing an awareness of what it means to think of patients and families as customers, and thinking of fellow employees as customers, and learning techniques to improve communication and listening skills. And then the third session on April 22nd, that one is going to be focused on developing an understanding of the voice of the customer. So the importance and use of a patient family advisory council or committee, and how to maintain that excellent patient experience. I'm not seeing any other questions come in from the chat box. So with that, I just want to thank everyone so much for your time today, and we look forward to seeing all of you again on the session next week.